Hello, how's it going? Good morning, everybody. Thank you guys all for coming here on your Saturday. And thank you, Dr. Masaki, for having me come back to speak to you guys. So, again, my name is Mike. I'm going to be talking to you guys a little bit about cataract surgery, what cataracts are, how we treat them, some of the options that you have. Uh, these are some of the financial disclosures. I speak for different pharmaceutical and surgical companies, but none of which have a conflict of interest today. Just getting a sense, has anybody had cataract surgery here? If you just raise your hand. Oh, yeah, perfect. A lot of you guys. And who has cataracts and has not yet had cataract surgery here? Okay, so perfect. So it's kind of a even mix. So again, I was born and raised here, went to JABSOM, came back here to practice, and I practiced at POB1 at Queens. So today we're going to talk about the basic anatomy of the eye as it pertains to cataracts and what we do for cataract surgery. We're going to talk about what they are, how it impacts your vision, and then we will be going through some surgical videos. So if you guys are a little bit squeamish, you can close your eyes for those. But in my opinion, they're pretty cool. So the eye itself is very similar to a camera. We have a lens that helps to focus light onto the film of the camera, which is the retina, and that is the lens that slowly develops into a cataract as we get older. And in order for you to also have good vision, your film of the camera, which is your retina, also has to be working properly. And that can degenerate in different conditions like macular degeneration, if there's bleeding in the back of the eye. And finally, there's a cord called the optic nerve that connects the eyeball to the brain. So it's kind of like the HDMI cord that connects your computer monitor to your computer. All three of those have to work really well for you to get good vision. And cataract surgery just replaces the lens inside the eye. Normally, in a person that has perfect 20/20 vision, their light is focused right on the retina. So you can imagine a magnifying glass being focused exactly on that point of the retina. In somebody that's nearsighted, their eye is a little bit larger and longer than the normal eye. So the focus point is in front of the retina, right here. And in somebody that's farsighted, their focal point is focused over here. And that's usually due to their eye being a little bit smaller than normal. So the correction for that prior to cataracts is pretty easy. We just give a pair of glasses or contact lenses, it refocuses the light and it puts it on the retina, and you can see 20/20 in the distance. Same for being farsighted. You put a condensing lens and you put the lens to move the light more forward. And again, you get 20/20 distance vision. For cataract surgery, it's kind of like we're putting those lenses right inside your eye. It's kind of custom fit for however large or small your eye is to get you the vision that you want. And so this is a little video on
Normally,
cataract.
the eye's lens is clear, allowing light rays to pass through and focus as they should on the retina. As a cataract forms, the lens gradually becomes cloudy. As light passes through this cloudy lens, it cannot focus clearly on the retina, and objects look hazy or blurred.
So, the question is, will this happen to you? The answer is yes. So if you live long enough, and hopefully we're living very long, this will happen to you. And will every cataract become visually significant where we have to take it out? The answer is no. But in general, in most people, it does start to bother them at some point. So in general, the average age for cataract surgery is about 70. Some people take till 95 to get the lenses out. Some people are as early as 40 or in their late 30s. It all depends on your health and some other factors that we'll talk about later. And the symptoms of a cataract can be blurry vision, double vision or ghosting of images, sensitivity to light, or glares or halos, or trouble with night vision. Anybody raise their hand if they have trouble driving at night? Explain the glare halos. Yeah, I mean, a lot of that can be due to cataracts, but also part of that is due to the aging eye. Needing more light when you're reading at night, it's because the cataract is blocking a lot of the light coming in. You feel like you have to have more overhead light to see an image clearly. And as that cataract turns colors, it changes your perception of your color. It changes your color vision. So it can make things appear faded or yellow. And so what causes a cataract? In general, most commonly, it's just the natural degeneration of the lens proteins in your eye. When you're born, it's super clear. There's no cataract, but as we get older, especially after the age of 40, those lens proteins begin to degenerate and they turn a little bit more cloudy. Now, there are different conditions such as diabetes, having had trauma, radiation, or steroids that can accelerate that breakdown of the protein to give you another cataract. Also, the sun, a lot of exposure to the sunlight can cause certain types of cataracts. Those can influence whether or not you develop the cataracts before 70, after 70. And is there something that you can do to slow the progression of the cataracts? And absolutely. So, in general, number one, wear sun protection. So, sunglasses when you're going out in the sun, not only does that help you prevent and or slow down the rate of progression of your cataracts, but it's also good for diseases like macular degeneration. Stop smoking. Smoking can accelerate the growth of cataracts, and taking better care of your body. People with high elevated sugars from diabetes, they develop cataracts a lot quicker. And it's a certain type of cataract that develops in diabetes. And once I have a cataract, for half of you that raised your hands, what should you do? So in general, you should be watched every year. So go to your eye doctor every year. We can watch and monitor the progression of your cataract, protect your eyes from UV light by using glasses, taking better care of your health by stopping smoking. You can use brighter lights to read or for activities that you're having a little bit more trouble doing. And limit your night driving, especially if you're feeling uncomfortable driving at night. And update your glasses or contact lenses until your doctor says it's ready for surgery. And when surgery is ready, there's actually two different, well, yeah, that's the historical treatments. Anybody know how cataracts were treated before? Yeah, okay, so back in the day, 5th century BC, they didn't really have any good surgical techniques. So they got a large needle and literally went through the eye, pushed the lens to the back of the eye. Over 80% went blind. That's not a good way to treat. But for the 20% that didn't go blind, and you go blind painfully in this scenario because the lens proteins are very pro-inflammatory, or you detach your retina. So it's either one. But for the 20%, you could see again. That's all they had back then. So thankfully, other techniques were developed. And in the 1980s, they had something called an extracapsular cataract surgery. And that was when they made this huge incision. So they kind of flayed open the eye halfway and they took the lens out in its entirety. And a lot of times they used a really cold probe called a cryoprobe and they touched it to the lens and they ripped everything out. They did not put a lens back in its place. So that's when you see people with these super, super Coke bottle glasses. They're very thick. They're called aphakic lenses. We don't see that very much anymore because this surgery is not done anymore. Then from the 1980s and even to now, there's a technique called small incision cataract surgery, where you still have about a 6 millimeter incision, which is a pretty large incision compared to the 2.4 millimeter incisions that we use now. But we can go to third world countries, and it's even done here for super dense lenses on special occasions. But in third world countries, they do this with minimal instruments. We don't have to have actually any power to do this. This is me in Ghana doing these surgeries where we open up the lens, we leave what we call a capsular bag, the structure that holds the lens in place. We leave that intact. We remove the lens in its entirety, and we replace it with a new lens, and so it allows them to see it better.
The third type of surgery is called small incision cataract surgery, or SICS. This is performed by making an incision of 6 to 7 mm in the form of a tunnel through the sclera and cornea. The lens is removed and replaced with a rigid lens implant through this tunnel. No sutures are needed as the tiny incision will heal naturally by itself.
And so I just want to give a shout out to the Himalayan Cataract Project. So Jeff Tabin, who's now a professor at Stanford, he leads this global effort to not necessarily cure blindness, but to help a lot of the underserved populations. So they go to Ghana, Ethiopia, India, and what they do is they go to these areas, and prior to them coming down, they recruit the help of a lot of local people, local eye doctors, to see who needs the most help, especially in rural communities. And we go down there and then we teach the local eye doctors how to do the surgeries, how to care for the people after, so that when we leave, it's a sustainable model. They can continue to do the surgeries. They can continue to help the people in that country, in those underserved areas, to get cataract surgery. So this is when we went down to Ghana, and in cataract surgery here, we removed the lens in its entirety. So these are what the cataracts look like in whole after we remove it from the eye. And so moving on, after kind of like the 1980s to 1990s, the traditional cataract surgery called phacoemulsification was used, and we used a lot smaller incisions to get that out and an ultrasonic probe. Oh.
During cataract surgery, your ophthalmologist will make a small opening in the side of your cornea. He or she will insert a pen-shaped instrument through the opening to reach the lens. This instrument uses a special type of energy to break up the center of the cloudy lens. Then it will carefully suction out the lens pieces. Your surgeon will then insert an artificial lens called an intraocular lens, or IOL. This IOL will stay in your eye permanently. The new lens lets light pass through and focus properly on the retina, bringing back clear vision.
So you can imagine the cataract as like a grape. There's a very thin skin of the grape that holds the lens in place. And that skin we try to keep intact for our surgery. We're going to try to make about a 5 millimeter circle in the front of the grape and then take all of the meat of the grape out by leaving the skin intact. Then we're going to put a new lens in the old skin, and that's going to scar down and keep the lens in place. The skin of the grape is very thin. So the back is 2 microns thin. So that's about the thickness of 1 red blood cell. So we just have to be very careful when we're skinning the grape and taking the lens out during surgery. So this was like almost a decade ago of me doing just standard cataract surgery. There's no lasers involved. So we'll put a jelly in the eye, kind of skinning the grape here, trying to make a perfect 5 millimeter circle that we're going to remove the lens from. And then we manually go in and break up the lens into quadrants. This is a technique called stop and chop. And cataract surgery takes about maybe 6 to 8 minutes. I guess it depends on who's doing the surgery, but we put the new lens in, remove the jelly in the eye, and then they can see better. And so now, like the most kind of current generation from 2010 is something called femtosecond laser-assisted cataract surgery. So just call it laser cataract surgery. This is a little video that kind of highlights the difference between laser cataract surgery and traditional cataract surgery. I don't have any financial interest in Ally. They just had kind of the best educational video, so I'm using it. But this is what we use at our surgery center.
In this video, we will look at the differences between a manual cataract procedure and a laser cataract procedure using the personalized Ally laser system. This will help you better understand your options so you can talk with your surgeon about the right procedure for your visual needs. As you age, the lens in your eye can become cloudy, making it harder for you to see. As part of the cataract procedure, the cloudy lens is removed and replaced with an artificial intraocular lens, or IOL. During a manual cataract procedure, the surgeon uses a blade to make incisions in your eye and create an opening in the capsule to get access to the cataract lens. This is a critical step in cataract surgery because it can affect how a new implanted lens will be positioned in the eye. If it's not done with high accuracy, the position of the lens could be off alignment, which may affect your vision after the procedure. The next step in the procedure is the removal of the cloudy lens. So
this is the way that you guys just saw me do it in the prior video.
Pieces in preparation to remove it. A handheld instrument may be used first to break up the lens into a few large pieces. Then, ultrasonic energy is used to break it up into smaller pieces before it can be suctioned out. It's important to note that when less energy is used in the eye to remove the cataract, the quicker the vision will recover. Less energy also reduces the chances of complications. After the cloudy lens is removed, a new IOL is placed into the capsule where your natural lens used to be. Opting for a laser cataract procedure with the next generation features of the Ally laser system provides more personalization, precision, and accuracy during the critical steps of the procedure. The Ally Laser System's advanced imaging system provides your surgeon with a 3D view of your eye. This allows for more detailed information and treatment choices during your cataract removal procedure. With Ally Laser Cataract Surgery, the capsule opening is created first. Guided by Ally's detailed image, the surgeon accurately places the laser spots in a circular pattern to create the opening. Because the laser allows for such accuracy during the capsular opening, positioning of the new IOL can be optimized, which may lead to an improved visual outcome. The next step is to soften the cataract to make it easier to remove. The instruments used in manual surgery are replaced with a personalized, precise, and accurate laser. This step considers the type and density of your cataract and helps to minimize the need for ultrasonic energy to break up the lens. And in some cases, Ally has eliminated the need for ultrasonic energy. This may reduce the risk of certain complications and potentially speed up healing time. After the lens is softened, the capsular opening can easily be removed. Once the cataract is removed, the new IOL is placed inside the capsule. If you have astigmatism, it can also be corrected at this point in the procedure by making tiny incisions on the eye to reshape it or by adding a special IOL called a toric IOL. Astigmatism is a highly common condition that happens when the eye is shaped like a football instead of a baseball. It affects your near and distance vision, causing blurriness or double vision. Your surgeon can now use the Ally laser to help guide treatment of your astigmatism during your cataract surgery, thanks to the advanced features of the laser system. Depending on the amount of astigmatism you have, your surgeon may use the laser to create small incisions on your eye to reshape it. These incisions can be made more precisely with a laser, compared to manually making them with a blade. If you have a greater amount of astigmatism, your surgeon may recommend a special or toric IOL to correct it. The Ally system helps your surgeon to precisely align the toric IOL where it needs to be. Because of how a toric IOL works, it must be accurately aligned in the eye in order to provide the best visual outcome. In a toric IOL manual procedure, proper alignment relies on hand-drawn ink markings made on the surface of the eye, which can run or fade during the procedure. Any inaccuracies can lead to misalignment of the toric IOL and may affect your vision after surgery. Ally helps eliminate any potential alignment inaccuracies, giving you the opportunity to restore your vision to its full potential. By choosing Ally Laser Cataract and Astigmatism Surgery, you are choosing the most advanced procedure possible.
Okay, so this is just like a live show. This is just some of my surgeries. So this is what an Ally surgery actually looks like. Once we dock with the eye is now docked and suctioned onto the laser, so it can't move. And then it'll show me making the capsulorhexis, and then it'll cut in the cornea over here to correct for their astigmatism. So this is just kind of in real time. The capsulorhexis is done already. Took like 2 seconds or so. And then now it's fragmenting the lens for us. It cut the lens into pieces, so I don't have to do all of that stuff manually. And then now it's making incisions in the cornea to decrease that football shape and make it more spherical. And so again, for astigmatism, basically, in an ideal world, the cornea or the front of the eye should be shaped like a baseball or a basketball. It should be perfectly spherical. In that scenario, light is focused at one clear point in the back of your eye, and you have a clear image. But in actuality, most of us have some football shape to our cornea, and however much football shape that's called your level of astigmatism, and that can distort the images coming through the eye.
Astigmatism is when the cornea is unevenly curved. Usually the eye is round like a baseball, but with astigmatism, it is more oval-shaped like a football. Light passing through this unevenly shaped cornea is not properly focused on the retina. Distance and close vision may both appear blurry.
So if you have a lot of residual corneal astigmatism after the cataract surgery, you still can have blurry vision if it's not corrected for. But if you don't mind that, then we can correct that easily with glasses or contact lenses after the surgery. But there are now really cool options to correct for all of that stuff during our surgery. But not all astigmatism is bad. Some small amounts of astigmatism is actually pretty good. It extends the range of your vision. And your doctor can, help to talk to you about the pros and cons of correcting for all or some of that astigmatism. And so this is putting it all together. This is a patient that I did where they opted for laser-assisted cataract surgery with a multifocal lens. We'll talk about the different types of lenses, but the multifocal lens allows people to see at a wider range of their vision, seeing distance, intermediate, and up close. There's, again, pros and cons to each of the lenses, which we'll talk briefly about after. And this person had a high level of astigmatism. So we use the laser to help align the lens, and then some augmented reality things that we have intraoperatively called the aura, which allows us to measure your astigmatism in real time. Once we remove the lens, we can take intraoperative calculations to see whether or not that lens that we put in its correct orientation, will neutralize your astigmatism. So this is after the laser is done. I go into the eye, and then I don't have to do the capsulorhexis. It's already done for me. I kind of just pre-break up the lens pieces that were already cut up by the laser. And remove those lens pieces. And this is called the cortex. So there's like a residual layer that's stuck onto the capsule that we just try to remove there. And these are the alignments that the laser already made. After we look at your iris registration at the time in our clinic, and we take pictures of your eye. So it talks with the laser that we have in the operating room. So it knows exactly the degree in which to correct your astigmatism. And then this is us looking at intraoperative aberrometry. So this is an augmented reality overlay that we have during the time of surgery to measure your axis of astigmatism. And you can see the dotted lines on the lens match perfectly with the capsulorhexis and the augmented reality. So we have a high level of confidence that the astigmatism will be neutralized and that the lens is in its correct position. All right. And so lens options, there's so many, sometimes it's kind of overwhelming to think about all the different options that we have. But I'll talk briefly on some of the big categories. I will say with one caveat, some people, they come and it's time for cataract surgery. They're so excited and they have their friend had a multifocal lens or this one type of lens that allows them to see really well in like certain situations. I would say that the majority of, well, I don't say the majority of people, but maybe about 40% of people are kind of really good candidates for multifocal lenses, but over 50% of people are not. And that relates to other underlying conditions. If they have glaucoma, if they have macular degeneration, if they have an odd shape to the front of the eye. So if they have something called irregular astigmatism, so in regular astigmatism, the eye is shaped like a football. That's easily corrected for because the laces of the football is exactly where we have to neutralize. But if it looks more like Haleakala crater, where there's a bunch of ups and downs, that's not correctable by a lens correcting in one axis. You know what I mean? So that's something called irregular astigmatism, which is not that uncommon. If they have diseases of their cornea, those can limit the visual potential after cataract surgery. So if anybody has those things, we know now from the data that they're probably going to be unhappy in a multifocal lens. You can put a multifocal lens in their eye, but they may complain that after the cataract surgery, like, hey, I see okay, but I don't really see very clearly at any of the distances. So we'll look at all of those factors and help you kind of guide that discussion of which lens is best for you. So one of the most common lenses that's implanted in the eye all over the world are something called a monofocal lens. That lens focuses light at just one distance. And in general, we pick from three categories. You can have stellar distance vision, intermediate vision, which is about arm's length from you. That kind of gives you good vision from working at a computer. When you're cooking on the counter, it's kind of counter distance, or near vision, where you can read up close. So computers over here, readings over here, and distance is out in the past about 7 or 10 feet. So you can also get a combination. So one eye gets good distance, one eye gets good intermediate or good up close. That's called monovision or mini monovision. And in general, if you've never tried monovision or never done monovision in the past, we don't do kind of full-on monovision. It's not the time to experiment when we're doing surgery in the eye. We can do a trial of a contact lens to see if you really like it, or some people after 40, to correct for their presbyopia, they were already placed in monovision where you have one distance and one near, like my dad, who had LASIK before. For brains that love monovision, we try to keep them in monovision after, and it works really well. You don't have the downsides of a multifocal lens, but you have the benefit of a wider range of vision. There are toric lenses, which also focus light at just one area, so either distance, intermediate, or up close, but these correct for high levels of regular astigmatism. And there's EDOF lenses, or extended depth of focus lenses, where they give you really good vision at one area, so most commonly in the distance, and extend the range up to intermediate. So this lens is the Vivity lens, which gives you about like 70% of the light being shown in the distance and 30% being intermittent at the intermediate range. And then the full-on multifocal lenses, they give the widest range of vision. So you get good distance, intermediate, and up close. But in general, there's only 100% of light that we can play with, right? Like you can think of it as 100% of photons. If 100% is going to the distance, that's the absolute best distance vision that you're going to get. So if you're really focused on distance or reading, and you want 100% of the light there, you'll choose a monofocal lens there. The multifocal lenses, they split the light. So 30% goes from the distance, 30% intermediate, 30% up close, for an example. There are different types of multifocal lenses, and different types kind of play with those percentages, either a little bit more toward the distance, a little bit more reading. Your surgeon can talk to you about those different types of multifocal lenses, but in general, 100% of the light's not in the distance, intermediate, or up close. So there's a decrease in what we call contrast sensitivity. So the absolute clarity at all of those ranges will be a little bit decreased. So it's not going to be the most clear distance. It's not going to be the most clear up close. But for most people that don't matter, it doesn't matter to them. That can be a really, really, really great option if they're not looking for the absolute most clarity. But for functional vision, people that get those lenses that are really good candidates for those lenses, they don't need glasses 80% of the time for most of the activities they do. And so if they're going to sit down and read a novel or something, they may put on some cheaters or some reading glasses. Or, you know, if they're going to go on a long road trip, they may put on glasses that optimize more of their vision to the distance. But for most of the things that they do from a day-to-day life perspective, they can be out of spectacles. So that's kind of the pros and cons, very briefly, of those lenses. And with the multifocal lenses, you do induce, because of the diffractive technology in that lens, there are a lot more glare and halos at night. Not everybody experiences them, but there are more, significantly more compared to a monofocal lens, which has less visual aberrations. And lastly, the newest lens to market is something called the light adjustable lens, which not everybody, I would say, is a great candidate for, but if you are a really good candidate for, it's a pretty cool lens. What it does is it's essentially a monofocal lens, so it focuses light at one distance. But has anybody had PRK or LASIK here before? Can you raise your hand? LASIK, yeah. So in people that have had procedures to their eye before, like PRK or LASIK, or have changed the surface of their eye at all, there are many conditions that can affect the front of their eye. There's a kind of a cost to that. When you do cataract surgery, the measurements that we do, they're off because the eye was previously cut and put back together. So it's not as accurate. So in those types of eyes, we have a lot of cool formulas now that get us pretty close, but it's not as good as an eye that's never had a procedure or has a normal cornea. For those people, they can be actually quite off on your target after cataract surgery. So this light adjustable lens is actually really good for the people that have had LASIK or PRK or had corneal issues in the past. You can put the lens in, then they go back after the fact on multiple occasions, and we check like how close it is to your target, and they can adjust the lens with a light to get you more nearsightedness or more distance vision, depending on what you want. And so again, I don't speak for the lens division of Alcon, but this is just a good educational video on, in general, what an EDOF lens does and a multifocal lens does. Again, there are many different types of lenses. I'm not financially, driven by any of this stuff.
Clarion PanOptix lens provides your patients with a full range of vision.
This is the full kind of multifocal lens.
The possibility of 20/20 at near, intermediate, and distance on a single lens design. Alcon reimagined multifocal performance.
First, we created an additional focal point at 120 centimeters. Then, we redirected the new focal point's light energy to distance. This created 3 optimally placed focal points, one at 40 centimeters near, one at 60 centimeters intermediate, and at distance. The result is an uninterrupted range of vision. The PanOptix IOL is the first and only trifocal lens to give patients the possibility of 20/20 at near, 20/20 at a more comfortable 60 centimeter intermediate focal point, and 20/20 at distance. If a patient is not a candidate for PanOptix, the Clarion collection offers more options for more patients, including Clarion Vivity, the first and only non-diffractive presbyopia mitigating IOL.
So this is the EDOF lens, kind of like a mini multifocal lens, if you will.
Work together to stretch and shift the wavefront, creating an extended focal range. With this extended focal range, patients can experience 20/20 at distance, 20/25 or better at intermediate, and 20/32 at near. Clarion Pan.
Right. And so should you be afraid of cataract surgery? Because, I mean, nobody really wants to do surgery. It's totally normal for you guys to have fears or anxieties, but cataract surgery is actually the most commonly performed surgery in the entire world. And it's one of the safest procedures, thankfully. General cataract surgery takes less than 10 minutes for us to do. There should not be any pain. You'll get pleasantly sedated as well. I would say half of my patients end up falling asleep during the procedure. Half enjoy kind of like a psychedelic light show. And you spend about 30 minutes in recovery and you go home that same day. What is the typical recovery time for cataract surgery? It's a lot of questions that people ask. And most cases of visual recovery are rapid, but it depends on your eye, to be honest. Depends on how complex the case was, how dense the lens was, how much power we needed to remove that lens, if you have any other underlying conditions that can slow or hamper the removal of the cataract. But if it's a soft lens and, you know, there's not that much energy used, you can see 20/20 as soon as the next day. In general, for the restrictions, at least the things that I tell the patients, I say that there's 4 rules. The first one is do not rub your eye, because we don't use stitches. Everything is a self-sealing wound. If you rub your eye really hard after surgery, you can get some bacteria in there. You can cause an infection or dislodge the lens. Number 2 is when you're sleeping, you're going to wear a shield over the eye for 1 week, and that'll help to prevent you from rubbing your eye subconsciously when you're asleep. Number 3 is try to keep the eye dry. I let my patients shower even the next day after cataract surgery. A little bit of water gets in, that's okay, but no swimming and submerging your eye underwater for a week. Actually, for the no swimming for a month for me. Number 4, just kind of taking it easy. You can resume normal walking around the block or kind of normal household physical activities the very next day after cataract surgery. But I don't want anything strenuous like Zumba or lifting weights or anything like that for about a week. And so in general, for cataracts, most people will end up getting cataract surgery, and that's okay. Surgery is very safe. It can improve your vision, and it can kind of try to help to meet your visual goals to get you less independent of glasses or maybe even out of your glasses or contact lenses. There are so many different options, and even the options that I discuss here by next year will be different. The lens technologies evolve so rapidly that, you know, talking to your cataract surgeon prior to having cataract surgery will be, you know, kind of like an ever-changing experience. So the recovery time is fast, and I don't know how many of you guys were here for the Old Wives' Tales last year. Okay, good. So dispelling old wives' tales, many of these were told to be by my mother and father sitting right there, which I found out later was not true, but sitting too close to the TV will ruin your eyes. True or false? False. That's correct. You can watch TV at whatever distance you want. So true or false? Your vision will get worse if you read in the dark. False. Correct. You don't have to. It's just harder to read in the dark. Wearing glasses makes your eyes dependent on them. False. Again, yes, you just have better vision when you're wearing your glasses. Wearing glasses with the wrong prescription will ruin your eyes. And one caveat is as an adult. False, correct. So I put the adult thing because that's important for kids, especially under the age of 8. They need to be in the correct prescription. That's super important because your eyes are developing all the way from 8 to 12, most say 8. But there's some like kind of play over there. But anybody have heard of amblyopia or like a lazy eye? So yeah, exactly. So how that develops is when one eye is not seeing well, the brain is very good at conserving resources. It'll ignore that eye and it will not develop that eye neurologically, especially before the age of 8. So if you have any grandkids or kids that have cross-eyed, or that you notice that they're not really using one of the eyes, or one eye drifts out or inward, they need to go see a pediatric ophthalmologist to get a correct prescription for their glasses, to realign the eyes to make sure that both are working properly, or that eye will not develop well. And if it doesn't develop well by 8 or 12, forever that eye will not be able to see that well. So that's how you get a lazy eye, or amblyopia. So as an adult, doesn't matter. You just see more clear with the right prescription. It's not going to push you in one direction. Well, one caveat to that as well is that there's some studies that just came out in China, were the biggest ones, where they looked at the rate of myopia, or being nearsighted, and it was significantly linked to near work. And so you'll see some studies on cell phone use, and cell phone use is kind of up close. People that were on iPads or iPhones were more likely to develop higher orders of nearsightedness. So the recommendation of having 1 hour or less of kind of screen time up here, that's where that came from. And those studies came out within the past 2 years. So it doesn't have to do with the prescription of your eye, just kind of happens to do with when you are younger, how much time you spend up close doing reading and phones and tablets, that can influence on how nearsighted you get. And eating carrots will make your eyesight better. So mostly false, because we get a lot of vitamin A in our diet anyway, but you need vitamin A from the carrots to have a good functioning eye. But the carrots won't make your eyesight better. But if you are vitamin A deficient, then you need some carrots, or take a multivitamin. And thank you again, Dr. Masaki, for having me. And thank you guys all for joining me this morning.
Thank you, Mike, for a wonderful presentation. The eye is so small. Isn't it amazing to see those surgeries being done? It's just really mind-boggling. So thank you for all you do. Do we have any questions from our audience? Oh, we have a lot. Okay.
Yeah, perfect.
You mentioned that diabetics had a special type of cataracts. What is that?
Oh, yeah. So they tend to develop something called a posterior subcapsular cataract. So again, you can think of your lens as a grape, and the grape can get cloudy in different areas. For people that have had steroids, or for people that have had high sugars in their eye, the back portion of the skin of the grape tends to become opacified, where the meat of the grape may not be very opacified. The meat of the grape, the yellowing of the lens, a lot of the cases that you saw here, that's more age-related protein degeneration. But the back skin of the grape can get affected by actually trauma, most commonly steroids or bad diabetes. And what you can think of it as, does anybody have a shower with glass? Yeah, so over time, after 5-10 years, that glass starts to get opacified with this kind of white stuff that accumulates. That's exactly what a posterior subcapsular cataract looks like. So we'll go in there, remove the cataract, and then we'll polish the back portion of that lens to get them better vision. Yeah, great question.
Well, my question is that I had cataract surgery about 13 years ago, and I made some adjustments, and they were like the laser thing that, broke up the cloudiness and all this stuff. But I assume that it lasts for your lifetime. But with all these changes in the different kinds of lenses and stuff like that, how many people, like after 13 years or whatever, go for the second one to get a different kind of lens or a newer kind of lens or whatever?
That's a great question. In general, so what I would recommend is not getting a different type of lens, because especially 13 years after your surgery, after you have cataract surgery, within weeks, that capsule, it starts to scar down onto the lens. And that scar tissue becomes very dense over time. And especially after several years, it becomes near impossible for you to dissect the old lens off of that scar tissue. It's kind of like if you got a knee replacement. If you got a knee replacement, you got some hardware in there and it didn't really fit well. within a couple of months, your surgeon can go back in there, remove that hardware, replace it. But after maybe 5 or 10 years, your bone has scarred onto that knee replacement, that hardware, making it extremely difficult to come out and probably more traumatic. So these lenses, these specialty lenses, they're designed to be in that one area, in your capsular bag. By 13 years out, the likelihood of them getting the lens out and putting it back into your capsular bag is very low. They'll likely have to remove that whole complex in its entirety and then stitch a lens in place. And the only lenses that you can stitch in place are monofocal lenses. So yeah, yeah. If you're within like the 1 year kind of postoperative period, yeah, you can get something called a lens exchange, where we can go back in there, reinflate the bag, remove the lens, cut it into pieces, take it out of the eye, put another lens in. Again, that's not ideal too, because with a lens exchange as well, your tissue is fragile, and that the back of that kind of skin of the grape is 2 microns thin. It's, you know, as thin as 1 red blood cell. It can rupture at the time of surgery, and if it ruptures, you may be, again, having to place or stitch a lens in place after that too. So. They did laser, yeah, correct. So that's something called posterior capsular opacification. So as that lens scars into place, the back of that capsule will opacify in 40% of people. So within several years after cataract surgery, 40% of people will need a little laser procedure to clean that lens. And that's not a problem. It takes us less than 60 seconds. You kind of sit in a device, it shines a special light. There's no pain. We clean the lens and you get your vision back.
Several times. I mean, if it
once it's cleaned, it'll never be need to clean again.
Oh, okay. So that was a one time.
Yep.
Okay, so I'll do with the glasses because I have to use glasses.
I know. Yeah.
Okay, with glasses.
Sorry.
I was wondering, I was talking to a retina specialist and they said if you're very nearsighted, using a multifocus lens when you get a cataract surgery can have problems later on. And also, if you have a monofocal lens and they say as you age, you get more farsighted, how does that affect if you have a lens and you're getting more farsighted?
Yes, that's a great question. So are you seeing the retina specialist because of your nearsightedness? Okay, why are you seeing the retina specialist? Macular pucker. So people that have things that are affecting the macula is a special area in your retina that is responsible for your central vision. So it's a very important part of our vision. When there are things affecting your central vision, you're not a good candidate for a multifocal lens because the complex optics of a multifocal lens splitting the light, it has to fall pretty perfectly on the back of the eye for you to actually gain a good quality range of vision. For macular pucker, in general, for most people, it's actually contraindicated to put that in. So the doctor could possibly get sued for putting that in because it'll look like from an outside ophthalmologist, that guy just wanted to make money. You know what I mean? Like you know already the pretest probability of that person being unhappy with that lens is super high. So none of us would recommend doing that. Now, say you were just nearsighted, you had a perfect macula, you could be a good candidate for a multifocal lens, but having a macular pucker, yeah, definitely get a monofocal lens.
There's something that you mentioned, sorry, over here, that you mentioned quite in passing.
Sorry.
And that was about wearing sunglasses to prevent macular degeneration. Can you say more about that?
So speaking on the macula again, so in general, macular degeneration is not super well understood. We know that there are certain genetic markers that predispose somebody to developing macular degeneration. And what macular degeneration is you can think about it as age-related degeneration, kind of like osteoarthritis in kind of like your knees and stuff, age-related degeneration in the central portion of the vision. And there are things that can accelerate the development of macular degeneration or worsen the development of macular degeneration if you have it. And one of the things is sunlight. So UV exposure into the macula. You can think of macular degeneration as if you have like a concrete sidewalk and you just built a new concrete sidewalk, that's in essence what your macula is when you're under 40. But over time, with sun, rain, people walking, driving on that concrete, it tends to break down. That breakdown you can think of as macular degeneration. And that sunlight kind of constantly baking that concrete is kind of like what's happening in your retina. So minimizing all the things that can accelerate its degeneration, that's the idea behind protective eyewear. And there are two different forms of macular degeneration. One is dry, which is kind of the good form, and that's kind of the wear and tear of the concrete. But sometimes that concrete degenerates so much that weeds from the grass below start to grow up. That's wet macular degeneration. That's when you get these new blood vessels that can break, bleed, and scar, and that can lead to a rapid decrease in your vision. And so that's one of the reasons why we say to decrease the UV exposure to your eyes, to also decrease the likelihood of going into wet macular degeneration.
Can you make some comment on cost and insurance coverage?
Oh, so that's, I would say it's so widely different. In general, if you do a standard cataract surgery, and there's no laser and you're just getting a monofocal lens, that's the kind of the lens that your insurance will cover. It's your insurance plan is anywhere from probably a 5 to a 20% copay. Probably be, I would say, less than $150, I would say, probably out-of-pocket cost. But don't even get me started on insurance companies. But they are, that's like a whole different topic. It totally depends on your insurance company, your plan, if it's an Advantage plan, if it's a commercial plan, if you have secondary coverage, what type of lens you're putting inside the eye, if you're using a laser, if you're getting a toric lens, if you're getting a multifocal lens. There's all these different kind of ranges of costs. So I would say it's best to probably talk to the doctor that you're going to get your cataract surgery from, and it ranges, yeah, for sure. So
I have a question on the Ally femtosecond laser.
Oh yeah,
yeah. What are the outcomes versus the normal type of? I guess I have a couple questions on that.
Yeah.
Normal type of I guess incisions, and do most ophthalmologists here have that? It sounds expensive. I wanted to know.
Yeah, the lasers are super expensive. So I could be wrong, but I think our surgery center is the only one in the state that has that one. That's the newest femtosecond laser that came to market. It came to market in 2023, and I think we were the 5th surgery center in the nation to have it. But in terms of the Ally, I don't. At least to my knowledge right now, I could be wrong. The other biggest one is at Dole. They could have bought one, but to my knowledge, they didn't buy one yet. I would say that in general, when you're talking about, so I won't kind of talk about the Ally, but I'll just talk about laser versus traditional cataract surgery. I think the bottom line is that you can have really great results with both. It depends on the eye that you're doing and what type of lens that you're doing and how dense the cataract is. Where laser-assisted cataract surgery really shines are in people that have really dense lenses. So in general, that probe that you see kind of entering the eye, it's an ultrasonic device, and it shakes like this and it shakes like this, and it's used to break up those lens pieces so that we can remove it in the eye. The more advanced the cataract is, it becomes hard like a rock. And the harder it is, basically the more energy we need to use to kind of jackhammer that thing out of the eye. So by using a laser-assisted cataract surgery where it cuts everything for you at the cost of 0 energy, your outcomes can be much better depending on the surgeon's comfort level. So in dense lenses and in cases, as the eye gets older, there's different layers of the cornea, which is the front of the eye. The innermost layer of the cornea is the most important. They have water pump cells that are constantly pumping out water to keep your cornea clear, to basically keep swelling away. If you remove those cells, your cornea becomes swollen and you could need a corneal transplant in the future. So those cells, they don't regenerate over time, and you lose those cells as you get older. So people with low amounts of those cells, and we can tell how much swelling or how your cells are doing prior to us doing the cataract surgery. If those cells are not functioning well, and especially if you have a dense cataract, using more energy inside the eye, it kills more of those cells. So it can lead to you having a lot more swelling in the front of your eye after cataract surgery, a slower recovery process, and long term may lead to you having to have a partial thickness corneal transplant in the future. So that disease is called Fuchs corneal endothelial dystrophy, and it's relatively common the older we get. Also, people can have decreased corneal endothelial cell populations from different things as well, trauma, infections. So Fuchs for things affecting the front of the eye, the density of the lens, and for astigmatism correction, I think it's so good. So if you have low orders of astigmatism, the laser, it has iris registration, so we know from the clinic exactly what axis your astigmatism is at, and the laser will then use those images and align itself to your eye, and it'll correct for those low orders of astigmatism automatically. And those do not involve us using a knife to just kind of cut in areas that we think that the astigmatism is. It's a much more precise way to correct for the astigmatism. And for higher orders of astigmatism, where we have to put in a toric lens in to align it properly, I don't know if you guys saw in the video, but the way that the laser cataract surgery does it is in the capsula rhexis, so making the incision in the kind of the skin of the grape, it already has the markers corrected for you to align that lens up. And it's much more accurate than the older way of doing astigmatism correction, which is you'll come into the operating room. I want to have you sit up. You know, like the leveling bubble that you do to kind of do construction? That's what we use. We try to get it level, and then we'll mark at 0 degrees, 90 degrees, 180 degrees with a pen mark. And we'll use those kind of marks, assuming that it was straight from you kind of sitting up, to then see like, okay, you need a 77-degree axis of astigmatism. Then we'll go after we mark your eye, we'll have you lie down, and then we'll use a little kind of handheld dial hit to kind of guesstimate where the 77 degrees of astigmatism correction is. And that pen mark is thick. It's like 10 degrees of unknown. So, I mean, if you're correcting for astigmatism, I would say it's worth it, you know. But say you're just getting a monofocal lens. Say you're like 65 or something, and the lens isn't that dense, and the outcomes aren't that much better for that. I mean, just go with the traditional cataract surgery, you know, because I think you can achieve really great outcomes. And one caveat is the laser-assisted cataract surgery is relatively a recent development. So it's like in the past decade and a half. If your surgeon is on the older side, they didn't train on laser-assisted cataract surgery, it's different from regular cataract surgery. So the bottom line is I would do what's best for what your surgeon feels best for, because even if laser-assisted cataract surgery may potentially be really good for your eye in the hands of a different surgeon, if the surgeon's not comfortable with that surgery, your outcome is not going to be good, or the chances of having a stellar outcome is not as good. And so just making sure that your surgeon is very comfortable with that, they trained on it, or even if they did it after training, that's totally fine as long as they are very comfortable doing that. Because although laser-assisted cataract surgery makes a lot of different critical steps of the surgery easier for us, certain steps are a little bit harder for us because of the use of the laser. So removing that cortex, that end piece, it tends to be sticky, what we call stickier. So it tends to take us a little bit longer to remove that, but everything else is faster. So it's like a kind of a pros and cons, kind of like a trade-off. But I would say at the end of the day, I would do what your surgeon recommends and they feel comfortable with.
Thank you so much.
Yeah.
We have time for only one last question.
Will the cataracts develop simultaneously and with equal severity in both eyes, or could one eye become affected more?
Oh yeah, so
other?
the most common,
when you do go to get surgery, do you usually do both eyes at once, or can you do one at a time?
that's a really good question. So they both, I would say the answer varies. I would say 90% of people, the cataracts progress. I'd say like 80% of people, the cataracts progress very similarly, but almost always one eye is worse than the other. It's kind of like if you got arthritis in your knees. Usually one knee hurts more than the other, but you still got arthritis in both. Usually they're more symptomatic in one eye versus the other eye, but by the time they're symptomatic, they'll benefit from cataract surgery in both eyes 80% of the time. Now, the exceptions for that is, say they had bad diabetes, or they were steroids, or they got punched in the eye, they had trauma, they had a chemical exposure to the eye. There are many different causes of asymmetric cataract growth. And if only one eye, say you're like 50 years old, and one eye has a very visually significant cataract and the other eye has no cataract at all, we're just going to do surgery on the eye that has the visually significant cataract. There's so many different variables in that, but I would say the majority of people have, when it's time for cataract surgery, say 80% of the time, both eyes are visually significant. But there are so many exceptions to that kind of generalization. And in general, it's nice for the patient to have both eyes done 1 or 2 weeks apart, and so they can do the healing process just one time. And then you can match the eyes. You can do monovision or do your mini monovision. You can achieve their visual goals by optimizing the vision in both of their eyes. And then I would say a lot of the times too, if someone just wants one cataract surgery done, say totally fine, we'll do that one. I would say a lot of the time, by 1 week, they sign me up for the other eye. So I would talk to your surgeon about that too, because every eye is unique and different. But
Mike, thank you so much for wonderful presentation.
thank you for having me.